another podcast. Today we're going to continue with medications and we're going to have a look at another class, which is benzodiazepines. Now, when benzodiazepines first came out, they were used for a lot of different disorders. So they came out a couple of decades ago and they used to be thrown at pretty much everything because they have a very low therapeutic index. Now, over the years, they've become a lot more fine-tuned, and now we have a range of benzodiazepines which are targeted to be used for specific things based on their pharmacokinetics that we'll discuss. So generally speaking, when we talk about indications of benzodiazepines, we're generally associated with hyperactivity of either neural impulses or erratic behaviors like anxiety, things like that. In regards to how we can use it, we can use benzodiazepines for acute behavioral disturbances. Now we'll discuss more about what that means in just a bit. Diazepam is also popularly used for alcohol withdrawal syndrome as well. When it comes to our injectable midazolam, IV and IM version, it's used for current seizure activities. It's also used to control shivering in patients with hypothermia. Now, having a closer look at this acute severe behavioural disorder, it's a very, very big umbrella term that generally means anybody with violent or erratic behaviour, can even be hallucinations or delusions, but basically it's those behaviours and those thoughts that stop you as a clinician from being able to do your clinical assessment. Now, where it gets more difficult is it's often based on where you work is your levels of escalations that you can use for anyone who's having an acute severe behavioural disorder. Now, obviously, if somebody is violent and physically violent towards you, it's best not to approach them, to stay away from them and pretty much call in forces that can detain or even help restrain the person from hurting themselves. Now, that's the police, and even the military police have policies that support them. Certain clinical environments have policies on restraints, chemical restraints, things like that. But so you have to check where you're working to see what you are legally allowed to use. Generally speaking, the use of physical restraints is out unless you've been told otherwise. And the best point of call we have is de-escalation. So we want to de-escalate somebody down to a point that we can actually start our clinical investigation. Because what we may perceive as a mental health emergency can actually be a physical manifestation from hypothermia, acidosis, rhabdo, or other conditions that the person may have that are causing this acute erratic behavior. So we have to be able to rule that out. Now, where benzos come into play, we pretty much cannot use diazepam until the patient is willing to take it, which means if we are unable to get to the point that de-escalation techniques have actually worked, we can actually approach the patient, then that's where we stop. We stop until we get further help and we just keep trying to de-escalate. If they have, then we need approval from a medical officer what sort of sedation we can use. Now, the high-end combative or very aggressive behavior is generally taken care of by ketamines, things like that. When we're dealing with someone who's just anxious, restless, agitated slightly, then giving them a bit of diazepam oral can help get them to a state that you can do a proper physical examination. So just remember, always check with the organisation you're working with what your protocols are associated with acute severe behaviour disorders, especially when you're entertaining the idea of physical or chemical restraints, and always seek approval from the medical officers prior to giving our benzodiazepines for these patients. Okay, moving down, we'll have a quick discussion on pharmacodynamics. So when you look at the difference between our oral benzodiazepines and our IV midazolam, a general rule of thumb is they're both pretty well absorbed and they cross the blood-brain barrier pretty well, even though they have different routes of administration. So obviously the oral diazepam can meet its peak concentration at about the 1 to 1.5 hour mark, but it's what's known as a very long-acting benzodiazepine. Midazolam, on the other hand, is known as a short-acting benzo, and IV is always the preferred route, okay, because IV will happen very, very quickly. IM can take up to 30 minutes to absorb, and the half-life is double. So it takes longer for us to kick in. When you're dealing with emergency states like seizures, you want it to kick in quickly, but then it hangs around for a lot longer as well if you give it IM dose, which means you get the associated adverse effects for longer with a benzodiazepine, the drowsiness, those sort of things. You can't actually assess the patient, and you don't know if it's a true fatigue state post-ictal or if it's just the case of the benzodiazepine. So IM, midazolam, is what you use if you don't have a choice. If you have a choice, IV is the preferred way to go. Now, as far as the half-life of diazepam, a good rule of thumb, if you're dealing with patients over the age of 40, then studies have found that the half-life of diazepam is generally 1 hour for every year of their life over 40. That means if you're giving diazepam to a 75-year-old, it has about a 75-hour half-life. Okay, it's metabolized mostly in your liver, in your GIT, and it actually works higher, the higher rates of metabolism on patients that are lying down flat. So if you're giving it to patients, you want them to be able to lie down and relax. It's actually going to improve the metabolism of the drug because of the increased circulation going to the liver itself, which is pretty interesting. Now, moving down to what the drug actually does. We have to go all the way back to thinking about our neurotransmitters, and certain neurotransmitters in particular work with benzodiazepines. So when we're talking about a neurotransmitter, we either have the ones that excite, cause that action potential, or we have the neurotransmitter that inhibits or stops that action potential. Now, GABA, our gamma-aminobutyric acid, is the neurotransmitter associated with stopping the action potential. And that is the one that benzodiazepines will actually trigger. Now, if you imagine the states in which we're using benzodiazepines, okay, we've got the highly agitated states, we've got the seizures, we've got the shivering, so there's a huge amount of synaptic cleft activity associated with neurotransmitters. So the cleft itself is filled with neurotransmitters, and we have a huge amount of excitability happening, which is causing action potential after action potential after action potential. In the case of a grand mal seizure, you've got this happening right across the cranium in multiple different regions. You've just got sparks firing. Now, GABA is a neurotransmitter that stops these action potentials from occurring, and benzodiazepines will actually act as a tractor beam, if you will, on that post-synaptic cleft. So benzodiazepines will come along, they'll nestle into the receptor sites of the postsynaptic cleft, and then they'll attract your GABA neurotransmitter to activate those receptors. When GABA activates those receptors, it actually causes chloride to come in. Because chloride is an anion, it has a negative charge, it actually lowers that membrane threshold, the voltage, if you will. It doesn't change the threshold, but it changes the voltage of the actual axon, which stops the action potential being passed on, and therefore stopping the effects or the hyper effects that you're trying to stop by the use of benzos. Now, in the event you're given a benzo, you could imagine what the adverse effects and interactions are going to be. So the most common ones that we will find will be the drowsiness, the lethargy, and the fatigue associated with the benzos. It slows everything down a little bit, so you get that fatigue feeling. If you're giving the high-end doses of benzodiazepines, then that neurotransmitter blocking, for lack of a better term, but it's more like a stopping of the neurotransmitter impulses, can actually start to affect our motor function. And then that's where you'll get your neurological systems, and that's where you'll get your dizziness kicking in. Now, this is particularly the case if you mix benzodiazepines with opioids. You tend to have a heightened sedation effect and heightened risk of respiratory sedation as well. So just be aware of those two. You may not be mixing it, but the patient you're giving it to may have taken opioids, and then you're doubling down with the benzodiazepine, you can have this increased risk. Now, if somebody's on any particular drugs, you either have one or two options that occur. You have drugs that lessen the effects of benzodiazepines, and common ones of those is the oral contraceptive pill and any antifungals. And then you have those that heighten the effect of the benzodiazepine, like your phenytoin. So it's always best to check our interactions before moving on to administering benzodiazepines outside of that grand mal seizure or hypothermia management state. Okay, we'll just go through some quick clinical take-homes. Remember, when you're dealing with acute severe behavioural disorders, you always need to check with the doctor. And if in the event you give benzodiazepines to someone with these disorders, you need to monitor them. You need to monitor them to see if they need more sedation, a different type of sedative, but you also need to check if you don't go too far. If you go too far, then we'll have to start bringing in the realm of reversals, okay, which we don't always carry. Now, in the event you're treating seizures or shivering, IV midazolam is preferred because it's absorbed faster, its actions are greater, and it has a shorter half-life, which means you get over the dangerous period, and then the benzodiazepine is metabolized through the body, not having those prolonged effects. And when they say that benzos can affect memory, it has that amnesic effect, is often what's said. Patients need to be aware that the experience they have is actually the loss of long-term episodic memory. So when you break down memories, there's generally three broad memory classes of sensory, short-term, and long-term. But then if you go further and further and further into reading, long-term memory has even more branches to it as well. And one of those is our episodic memory. Now, this is the memory of a personal experience or event, and it involves the recall and recognition of information such as like stories that you heard. And benzos will actually impair that episodic memory, which means it links to its drug of addiction. So it's often abused for sleep, but it has been used as a date rape drug as well because of this effect that higher doses can have on our long-term episodic memory. So what that means for you as a clinician is just treat it like a drug of addiction, like an S8, and keep it under control and keep checking it, make sure it's not has been stolen and being abused. Now, when you're using it or choose to use it for hypothermia patients, it is only effective in patients that are shivering. There's no effect on patients that are just suffering from hypothermia, but in the event the hypothermia is causing thermoregulation, dysregulation, then you can get reciprocal shivering as a response to high temperatures as opposed to low temperatures. We want to turn that off because that muscular activity is just increasing the core temperature further. Okay, so that ends the lesson on benzodiazepine. I hope you got something out of it, and until next time, take care.